And Nirav, the
Sir, Shafbi name was not announced.
Jeff B is there. Jeff B is there. Red Jeff B is also there. Both are there.
So
Don't
we are live now.
don't worry. Don't worry.
YouTube live is there, na?
YouTube is live after 7:30.
Okay.
We can start the YouTube streaming now if possible.
We can start. Because
So it is
anyways, what
started
is
already.
Started. Yes. Okay. Okay.
because it is anyway seen on the Zoom.
If
Yeah,
anybody has any problems,
it's
please tell now.
it's
This is the
live
last
now. It's live.
done. If anybody has any issues, please let us know now.
So can we proceed with the first question?
Yes.
Yeah.
Start.
Rohinjan, video is off. Team Rohinjan, you are not visible.
Okay, so all 20 questions are completed and there was no glitch or no lag, no problems, and I hope all the teams were able to submit the answers for the 20 questions. So we will be soon ready with the results, and that will be shared with all of you after the discussion section. Now we will proceed with the discussion part of today's session, and we were privileged to have a list of faculty who helped us, who contributed the questions, and they are from different parts of the country, from north to south and from east to west. And I request Nirav to share the discussion presentation. So Gurpreet, I hope all teams were uh, following the instructions and the videos were on throughout the session. Gurpreet, you are muted.
Yes, yes, sir. Both videos are on and the audios are off, so it was better than the last two sessions.
Okay.
So,
So the results will be displayed by the after the end of the discussion, and all teams should check. And today we are going to announce the top 10 teams which will go to the next round, that is semi-final rounds, and that will be online again and a different format, not MCQ, and that is scheduled for 5th January evening time. So for the discussion session, we will start with Dr. Ravindra Kashyap. Dr. Ravindra, you are there?
Yes, sir,
Yeah,
am I
Dr.
audible?
Yeah. Also
yes,
switch
yes.
on your video, and Nirav, you have
Uh,
to pin the
okay. Sir,
faculty. Yeah.
I'm currently outside, so I will just switch on my
No.
audio.
Okay, no problem. So
Okay,
Dr.
thank you.
Ravindra Kashyap is faculty
Yes,
at Kovai Medical Center, KMCH, Coimbatore. So you can start with your questions.
yes, sir. Thank you, everyone, and thank you. I thank the organizers of AOCR quiz for giving me this opportunity. Moving on to the first question, it is a 6-month-old female infant with global developmental delay and microcephaly. As you can see in the MRI and the CT sections, you can see bilateral anterior temporal cysts, which is seen on the flare section, and there is diffuse cerebral atrophy with white matter leukodystrophy, and there is thinning of the brainstem, thinning of the corpus callosum, and bilateral basal ganglia calcifications. So these are the findings we have, and the options are Van der Naap disease, congenital CME infection, Aicardi-Goutieres syndrome, and congenital myotonic dystrophy. We can rule out Van der Naap disease and congenital myotonic dystrophy since they are associated with macrocephaly and not microcephaly, as you can see in the question. So you're left with two options. One is congenital CMV infection and Aicardi-Goutieres syndrome. Now, congenital CMV infection presents with periventricular calcifications and not basal ganglia calcifications. So this is why the answer for the first question is Aicardi-Goutieres syndrome. So moving on to the next question, it is a 45-year-old female teacher with neck pain and giddiness. The diagnosis, so you can see in the images, there is fusion of the C1 vertebra to the occiput, which is an atlanto-occipital assimilation. You can see in the first image in the coronal CT section bone window, and there is also degenerative changes involving the bilateral atlanto-axial joints. So that is seen in the first image. In the next two images, there is on a neutral position. These are the cone beam CT images with contrast injected this is catheter based angiogram of the right vertebral artery. And you can see in the CT angio images in the VR section, there is no occlusion of the bilateral vertebral arteries. And there is also no occlusion of the right PCA. And you can rule out Eagle syndrome because you don't have any images of the enlarged styloid process. So, in the neutral position and on extension, you can see that there is a partial dissection with thrombosis of the vertebral artery which happens on extension. And this is a female teacher. So whenever she turns her head towards one side, she gets giddiness and features of posterior circulation stroke. So the diagnosis here is Bow-Hunter's syndrome. Moving on to the next question, which of the following statements about the diagnosis is false? The imaging features you have on ultrasound and fetal MRI, there is a large cystic lesion arising from the lumbar region of the spine, and the lesion has echogenic walls on ultrasound, and there is a fibromuscular stalk extending from the spinal cord to the skin surface, and the same features are also redemonstrated on the fetal MRI. And the sagittal image of the brain has been put here to suggest that there is no features of Arnold-Chiari malformation. That is, there is no herniation of the posterior fossa structures below the level of the foramen magnum. So this is a diagnosis of a LDM, that is a limited dorsal myeloschisis, and this has to be differentiated from a myelomeningocele, which is an open spinal dystrophism, and it presents with features of Arnold-Chiari malformation. So the correct option is, it is an open spinal dystrophism is a false statement. It is a closed spinal dystrophism, and the echogenic wall of the lesion represents the skin covering. So this is a closed spinal dystrophism. So that is the answer, and all the other statements of this diagnosis are true. Moving on to the next question. So what is the diagnosis? The first two images are the axial and coronal sections of the fetal brain taken at NT scan at around 12 weeks, 5 days of gestation. And the next two images are the T2 weighted axial sections of the fetal brain taken during fetal MRI at 20 weeks. So in the NT scan, you can see bilateral symmetrical cystic lesions in the anterior portion of the choroid plexus. And you can mistake this to be a choroid plexus cyst, but it is not, as seen on the coronal sections. It is seen well away from the choroid plexus, and it is present anteriorly and causing mass effect on the bilateral lateral ventricles. And in 20 weeks, you can see that there is diffuse thinning of the cerebral parenchyma, delayed operculization, absent parieto-occipital sulcation, and bilateral lateral ventriculomegaly. There is also a dilated third ventricle, and the two hypointense structures seen adjacent to the lateral ventricles in the first image represents the enlarged ganglionic eminence. So this is a case of malformation of cortical development, which was diagnosed at 20 weeks, and the finding at the NT scan represents the ganglionic eminence cavitation. And this has to be differentiated from the other differentials like the subependymal pseudocyst, which is a benign condition, periventricular leukomalacia, which can happen during infarction of the fetal brain, and conatal cyst, which is again a benign condition, which happens due to the pinching of the frontal horns of the lateral ventricles. So this is a case of ganglionic eminence cavitation resulting in malformation of cortical development. Thank you.
Thank you,
Thanks.
Dr. Ravindra. Thank you very much for your valuable contribution today. So over to next faculty, Dr. Vaibhav Nichit. You are here, Dr. Vaibhav.
Yes, sir. Good evening.
Dr. Vaibhav, you can switch on your video if possible, and you can
Yeah,
start
sir.
with your discussion.
Yeah. So good evening, guys. Thank you, Nitin sir. Thank you, AOCR team, to give me this opportunity. So this
Neeraj, you
was
can
the
pin Dr. Vaibhav.
yeah. So this was the first case, guys. So if you see the X-ray first, here the history was given to you, was 23-year-old male presented with chronic frontal headache, recurrent cough and cold. So what will you do next? So if you see the X-ray is flipped. The marker is on the left side. So that means the heart is on the right side and the stomach is also on the right side. And on the X-ray as well as the coronal image of the CT scan, you can see there are varicose and cylindrical bronchiectatic changes involving right middle lobe and lingula. So obviously all these findings putting together, it points us towards the Cartagena syndrome, and Cartagena syndrome having four of its component. One is situs inversus, second is chronic sinusitis. Chronic sinusitis, we can guess it from the history. Third is bronchiectatic, and fourth one where the question is asking us what will you do next. So we'll do reproductive evaluation to look for infertility. Okay. Then coming to the second case.
Next slide.
Yeah. So here the history given to you was 6-year-old female undergoing dialysis. So this history is very important. Undergoing dialysis, presented with episode of hematuria. Plain MRI was performed, and here we can see one axial image of the T2 fat sat at the level of kidneys. And definitely on the left side, you can see some altered signal intensity structure. Could be some mass or something, we don't know, or it may be some complex cyst in the left kidney. And the image given to us points towards autosomal dominant polycystic kidney disease. So in order to further clarify and further characterize this lesion in the left kidney, the question is asking us what is the protocol of giving IV gadodiamide omniscan. So here the history is very important. The history is telling us that the patient is undergoing dialysis. So according to ACR 2024 contrast guidelines, if any patient is going under the dialysis, we don't need to calculate eGFR, okay, because the patient is already undergoing dialysis. If we give contrast, any CT contrast or MRI contrast, the patient is not going to get harm because of the contrast injection. So here the correct answer is no eGFR calculation needed. We can administer the contrast without any hesitancy. Next question, please. So here this is a case of 10-year-old female with multiple areas of swelling in hands and feet, underwent MRI, and the CT guided biopsy was also done. The question is asking us what will be the culture report. So if you see, you have been provided with coronal images of both the knee joints, both the ankle joints, both the wrist joint, and the last image is given is CT guided biopsy. So on coronal images of appendicular skeleton, you can see ill-defined areas of stir hyperintensity, predominantly involving distal metaphysis and extending across the growth plate into the epiphysis. So this is a case of CRMO, chronic recurrent multifocal osteomyelitis, which nowadays being recognized as chronic non-bacterial osteomyelitis. So CRMO, usually if you do culture in cases of CRMO, CNO, you will not get any organism culture in the report. So the correct answer over here is no growth. Next, please. Yeah. So this was the last scan. Here, the 20-day male child presented with high-grade fever and sepsis. USG and contrast study was done. The question is asking which of the following option best describes the percutaneous nephrostogram images. So coming to the first ultrasound image, which is taken with the high resolution linear probe, you can see that there are echoes within the dilated pelvic LACL system, which points towards that the patient is having pyonephrosis in a given clinical setting of high-grade fever and sepsis. And after percutaneous nephrostogram images, you can see the contrast is opacifying the lower moiety, which is having grade 4 hydronephrosis with loss of papillary impression. And further down, when the contrast is going into the proximal ureter, it is refluxing into the upper moiety, causing opacification of the upper moiety, which is not dilated. And lower down, so these two ureters are joining to form a single mid ureter and distal ureter. And in the last image, you can see the opening of the distal ureter is far below at the level of prostate, since the patient is a male child, and at the level of the bladder neck, which is not the orthotopic insertion of the ureter in normal cases. So this is, so in this case, the best explanation for percutaneous nephrostogram images is B, because here the pelvic LACL system is duplicated. distal ureter is single, and vesico-ureteric junction is ectopic. Thank you, guys. Sir, you are not audible.
Thank you very much, Dr. Vaibhav. Thank you for your valuable questions. And next is Dr. Joshita Singh, who is a well-known radiology consultant from Jupiter Hospital in Pune. She is a common faculty in IRIA and international forums. So over to Dr. Joshita.
Yeah. Okay, can I have the first slide?
Yes, next question.
Right. So the question you have a lateral radiograph of the knee, and the question is middle-aged gentleman lump around the knee. What is the most likely diagnosis? The correct answer is para-articular osteochondroma. So let's see first why the other answers are not correct. If this was a chronic calcified hematoma, typically you would get a peripheral kind of a calcification if there was a hematoma in the infrapatellar fat pad region. Hemangiomas, you can have some calcific densities in hemangiomas, but those would be like phleboliths, small intravascular rounded calcifications, not like this tumoral calcinosis. That would be periarticular calcification, usually associated with dysregulation of phosphate metabolism. So that is also incorrect. Now let's go on to why this is paraarticular osteochondroma. So what do you see? What you're seeing is a bony lesion, which is almost completely filling up the and confirming to the morphology of the infrapatellar fat pad, right? And it doesn't seem to be arising from any of the bones, so not arising from the patella, femur, or the tibia. So this is a bony lesion. So we know that this is likely to be a paraarticular osteochondroma because this is a characteristic location in that region. What this is it's basically an extraskeletal osteochondroma. So it has both cartilaginous and bony component, and it is not originating from any of the bones, and it does not originate or is not contiguous with the synovial lining of the joint as well. So since the infrapatellar fat pad is intraarticular but extrasynovial, so that is why this is a paraarticular osteochondroma. Let's go on to the next one. The next slide, yeah. So this is a 33-year-old lady with chorea and some emotional lability, and you are provided with T2 weighted axial images, flare, and that is susceptibility weighted images. Now, what you're seeing first on these images. So on the T2 weighted images, what you're seeing is you're seeing hyperintensity in the white matter that is sparing the subcortical white matter, and then you're seeing calcifications in the basal ganglia and the thalami, and then you're seeing some cysts in the periventricular white matter. So the question is, what is false for this diagnosis? So what is the diagnosis, first of all? This is leukoencephalopathy with calcification and cysts. So that is Lebrun's syndrome. The incorrect answer is autosomal dominant disorder due to mutation in SNOD118 gene, because this is an autosomal recessive condition. The gene that I've given you is the correct gene that is responsible for this condition. These patients can have seizures, or they can have pyramidal or extrapyramidal signs. And what mutation in this gene, what it does is it causes a ribosomopathy, which eventually results in cerebral microangiopathy. And these cysts, usually you tend to do the imaging follow-up for these cysts, because these cysts can enlarge, and then they can have symptoms from Mass Effect. And if they have symptoms from Mass Effect, then one needs to decompress these cysts. So B, C, and D were correct options. But since it's an autosomal recessive condition, A was the incorrect or the true answer for this question. Let's move on to the next question. The next slide.
Next question.
Right. So this is a young lady with forefoot pain. This is a T1 weighted image, and the bottom two rows are post contrast images. So what you're seeing is a spindle-shaped lesion in that's first, second, and third. So the third interspace between the two metatarsal heads, and that's fairly iso-intense to the muscle on T1 weighted images and shows some enhancement. You can see that it is located in the region of the neurovascular bundle. Compare it to the neurovascular bundle that you can visualize on the plantar aspect in the second interspace. So it's located in the region of the neurovascular bundle. So you're dealing with the Morton's neuroma. Now the question that was put for this case was, what is false with this entity? And the correct answer is size doesn't matter, because size does matter in these patients. The slide's gone off. If the transverse diameter is more than 5 millimeters, then those are the patients who are likely to be symptomatic, and those are the patients who are going to best respond to surgical treatment. Okay, so that is the correct answer for this question. I think.
Okay.
Yeah,
Thank you very much,
this
Dr.
is.
Joshita. Thank you. So we now have Dr. Abhinav Jain, who is professor and head at Hamdard Institute of Medical Science and Research, New Delhi. Dr. Abhinav, you are there?
Yeah, Dr. Nitin, thank you.
Yes, yes.
Uh,
You can start your questions.
Yes. So this is the first case which is actually a rare entity. When we did an ultrasound of this patient earlier, we found that there was a large mass-like lesion inside the brain, which had calcifications. And this newborn undergoes an MRI examination for evaluation of a suspected intracranial mass. These are the axial and coronal images, which are showing a well-contained mass lesion, which has a well-formed bone inside it, which looks like a total limb, and there were certain vertebrae also. So this lesion would classify for a fetus in fetu, a fetus which has been incarcerated inside the brain of the person. It cannot be a craniopharyngioma because there is no heterogeneity and the location is not that of craniopharyngioma. Germinoma would have, or intracranial lermoid cyst would have fat and fluid component, but it will not have a well-formed bone or any organ. Next slide, please. Yeah, so what you are seeing here is MRI of the neck, where you have a T1 weighted image, which shows a hyper-intense lesion, which is a well-marginated, lobulated lesion and is invading into the various anatomical regions of the neck. But it is not encroaching into any of the vascular or any other trachea or any other structures. So it's a very smoothly marginated benign lesion, which is appearing hyperintense on T2 as well as on T1 weighted image. And on fat suppressed image, it is homogeneously the image is suppressed. The T1 weighted fat, which is seen there, is totally suppressed. So on CT scan also, it shows a very well-defined fat density lesion. So it cannot be, so the differentials which would be there are liposarcoma of thyroid, but that will be an invasive mass invading into the adjacent structures, which this lesion is not doing. Thyroid invasive lipomatosis is a rare condition, but it shows infiltration into the surrounding structures. And the hallmark feature of this fatty lesion is confirmed on fat suppressed images, as we are seeing here. Thyroid lymphoma would be iso to hypointense on T1 weighted image and not hyperintense, and will not show fat suppression like it is showing here. Next slide, please. Yeah. So here we are seeing a large cystic lesion, which is showing CSF signal intensity continuous with the third ventricle, and it's invading into the sphenoid sinus. So transsphenoidal meningoceles are again a rare entity where there is herniation of the CSF and the meningeal membranes through the defect. It will not qualify for an empty sella because the empty sella will not be communicating with the sphenoid sinus, will not be associated with bony defects. Same is for Rathke's cleft cyst, and craniopharyngioma will have a solid component. So a classical CSF signal intensity lesion with meningeal herniation, a transsphenoidal meningocele. Next slide, please. Yeah. So over here you are seeing a 30-year-old female with acute pelvic pain, pervaginal bleeding and palpable vaginal mass. The MRI show the findings are also mentioned. It shows on axial scan it is showing a well-defined mass lesion which is seen inside the vaginal wall and is showing is surrounded by the vaginal fornices, classical bullseye sign. And in the other image, you are seeing a U-shaped structure where the uterus is seen prolapsing out of the into the vagina. So this is uterine inversion. It may be associated with postpartum hemorrhage. Usually may also be associated with mass lesions like fibroids or any other mass of the uterus, which is not a case here. Cervical polyp would be a pedunculated mass which will be projecting out of the cervix. So the answer is uterine inversion. That's all. Thank you.
Thank you, Dr. Abhinav. Thank you very much for those important, useful questions. And this is not only about quizzing, this is also about radiology learning. And it is important to learn the key points out of these questions at the same time. So next is Dr. Narendra Bodhe. He is head of the department radiology at AIMS Raipur. So Dr. Narendra, you are here? Yes,
Yeah,
yes.
I'm here. Am I
Yes,
audible?
sir. Yes, yes.
Yeah. So we start with the cases right away after thanking Dr. Nitin, my ever-time friend, and the team of quizzing here. So after this thing, the way what we see is the dirty output in the terms of melena in this 18-year-old male. Okay. So all the things, all the answers are there within the images and the history given, because at times within the short possible slide or the non-availability of a series of images, at times it may be difficult to diagnose a pseudoaneurysm. But when you say melena and this sort of picture is there in the second and third spots or the images which are there, which shows a dark spot, the CT itself shows that there is a contrast enhanced blotch, which is seen in the arterial phase of the contrast, and then you see the DSA, which is seen in the second, third, and fourth images. So the second and third images basically is showing an artery which is leading to the pseudoaneurysm, which is further leading to two branches like thing, which is going near the diaphragm, if you can see, and it is crossing the diaphragm, which is overlapping on the right part of the cardiac shadow. So it means basically there is some thing which is there in the lung, which is also supplied by the systemic artery. So basically, if you see the diagnosis for the melena here is a pseudoaneurysm or rather a bleeding artery, and there is no aneurysm sort of thing. So naturally, this second option is wrong, because the pseudoaneurysm is the one which keeps on, I mean, it is the leaking thing which keeps on happening, and that is how it's only a pseudoaneurysm. At the same time, what is happening here, as we see that the artery is supplying the supradiaphragmatic portion of some tissue, which naturally is in the lung. So that is a sequestration. So this is a diagnosis of this. I think it is jumping. It is jumping. Can you go back to the previous slide, please? Yeah. And the last slide, which is showing, is a continuous this thing, which is seen as if there is a blocked artery, and which is the embolized artery, which is not showing a sudden this thing. It is showing a embolized material. So that's a glue embolization which has been done, and this artery is basically an aberrant artery from the celiac trunk. It is not a gastroduodenal artery, which is very clear, which we can see this gastroduodenal artery should come a little down, and it is not the left gastric artery, because left gastric artery is clearly seen, and this is the aberrant artery which is coming from the celiac trunk, as you can see in the post embolization angiogram. So the next slide, please. The correct answer. So in this slide, this is a 20 years female. What is the likely CNS manifestation in this patient? So this clearly gives a diagnosis that both the renal areas that is the subhepatic as well as subsplenic areas, which are replaced by multiple fatty or hypodense areas, and not a small renal tissue only seen on both of these things, but not enhancing, but only a few areas which are seen to be enhancing. So naturally, this is a renal angiomyolipoma on both the sides, and which actually says that this is a part of a tuberous sclerosis, because the question asked is, what is the likely CNS manifestation? And when you say tuberous sclerosis, the cortical tubers or the subependymal giant cell tumors or astrocytoma is the one which is associated, and the likely presentation at times the patient comes with seizure, and the rest of these things get detected later. So a CP angle schwannoma or optic nerve sheath meningioma or a schizencephaly becomes less likely. It is a very clear answer. This should have been answered by almost everybody, that the correct answer is second, cortical tubers, subependymal giant cell astrocytoma, and seizures. That is the likely CNS manifestation. Thanks. I think next slide is somebody else. Okay, this slide is also mine. Okay.
Yes.
So this slide is of a 14-year male, and this is in the area of, as we say, the sphenopalatine area. So naturally, the diagnosis here becomes of an enhancing mass in the sphenopalatine area, as you see on the right side, and that is a juvenile nasal angiofibroma. And this catheter, which is seen in the lateral view of the DSA, the cases which are subjected to DSA in juvenile nasal angiofibroma is a part of a pre-operative embolization, if it is a catheter embolization, so that the surgeon can operate relatively in a bloodless field if it is done by a catheter, or else you do an angiogram and we can do a percutaneous or a direct puncture embolization also. The artery which is most of the times seen to be supplying is the branches of the internal maxillary artery, which is a branch of external carotid artery. So the middle meningeal artery should have been going posteriorly. Superficial temporal artery should have gone straight, and aberrant coursing internal carotid artery should have also gone straight and up. So the correct artery here is the internal maxillary artery. So thank you. I think these are my three cases. Thanks, team, and thanks, Nitin.
Thank you. Thank you very much, sir. So, Dr. Vijay Kumari, because of some emergency, she is not able to join. So, can we have the next question? So, this is an ultrasound B mode image and the color Doppler image, where we can see the thrombosis involving the left common femoral vein at a point where it is just posterior to the common femoral artery and anterior to the vertebral body. So, this is the point where the common femoral vein typically tend to compress and is called the May-Thurner syndrome. So that is why the left lower limb thrombosis is often more common in these patients, because at the site of compression there is a stasis of the blood flow. So next question. And these are the what is the condition depicted in the nuclear scan, and then there is a corresponding radiograph of the left lower limb in the region of ankle joint, and the options provided were trauma, infection, hypertrophic osteoarthropathy, and none of the above. As we can see the metabolic uptake in bilateral lower limbs, and we can see the corresponding periosteal reaction in along the medial surface of the distal tibia. So the correct option in this case is option C, hypertrophic osteoarthropathy. Next. So I think that's all. That's all. So that brings us to the end of the discussion section today. And just give us 2 minutes time, and we are going to share the top teams.
5 minutes. I think I'll just share the screen once the result is ready. It's in front of us. But
Yeah.
Santa Claus has come to us. It is Christmas, so we have some good news for everybody. Okay, so we have the results with us, and what we are going to do is we are just going to show the names of the top 12 teams. Yes, you heard me correctly. It's not 10 teams, it's 12 teams which will be selected for semifinals. And that is the good news. We are giving one more chance, like in all rounds, we have given chance to more people than what we had suggested. So just give me a second till I share my screen. Uh, just a second. Okay. Uh, okay. So everybody can see my screen right now. Gurpreet sir, Nitin sir.
Yes,
Yes,
yes.
yes, we can see.
I will
And
read aloud the name of the top 12
You have
teams,
to
and these are not
zoom it slightly.
okay.
Yes.
yes, bus.
So these are the name of the top 12 teams. They don't
Zoom
decide the
in.
rank of the teams. These are the just top 12 teams. Techie Tots, Dhanvantari, Mad Reds, Charaka, Vadamalayan Hospital, Wild Card, X-Rated, Wims Warrior, RML Second Years, Scantastic Duo, Emerald, and SMS Hospital.
These are the top 12 teams. Don't ask about the college affiliation. Don't ask about the ranks. These are the top 5 teams which goes to the next round,
That is
semifinals.
semifinals. Just stopping this.
Congratulations, congratulations to all the winners of these
Yes,
quiz, top 12
congratulations.
teams. Congratulations, you have done very well. It was a tough quiz. And the next round, a new group will be made for these 12 teams, and instructions will be given on that group. And Nitin sir, can we
Yeah.
wrap it up, or anything else we have to do now?
Yeah, so the new group will be created and only these 12 teams will be added. The rest of the instructions will follow on the group itself, and there will be
Congratulations
change in the
to all
format.
the participants also. They have done very well to reach here. It was the rounds were very, very tough. It was a tough quiz round, and we are preparing you all for the international event, and we hope many of you people reach there. So rest the instructions will be displayed on the group.
Yeah, and the teams who could not qualify, they should not be disappointed because you have done extremely well, but we have to find only few teams will go to the next round, then again only 5 teams will reach the finals. So this cycle will go on, and you have to be ready and be better prepared next time. So this should encourage you to be better prepared, read more, and look at more cases. All the best.
I would take this opportunity to thank Nitin sir, Nidhi ma'am, Gurpreet sir, Ankur sir, Team RX Events for spending the last 2 weeks. I think every day they had meetings and deciding the questions. Even till the last moment, they have just ruined their valuable weekend. At least last many weekends working for it. I would also like to thank all our esteemed faculties for sharing very interesting questions, and every time we also get to learn so many things. Uh, Nidhi ma'am, Ankur sir, Gurpreet sir, any last thoughts?
Yes, I think we should wrap it up, and we'll follow with the instructions in the newly made group, which we made in the next couple of days. Yes, Vana?
Great. Thank you, everybody.
Thank
Have a
you all. Thank you all. Thank you all. Neerav ji, please close the meeting.